With that in mind, let's move ahead to our next session, minimally invasive, maximally effective hand arthroscopy. I am honored to summon a distinguished chairperson, Dr. Prashant S., Dr. Darshan Kumar A. Jain, and Dr. Mikko Reisanen onto the dais. Over to you, sir.
Thank you for everyone for coming this session, and let's go straight ahead. We're a little bit late. So the first speaker is rising Asian star in arthroscopy, Zerin Jung from Singapore.
Hello, okay. So thank you, chairpersons, for having me here. It's been an honor to speak. So I'll be talking today on arthroscopic management of scapholunate complex lesion. So the scapholunate joint is stabilized not only by the interosseous ligament, but also by the secondary stabilizers, namely the DIC ligament, the volar radiocarpal ligaments, SCT ligament complex, and so on. If you look at this famous video by the dissection by Drs. Murato and Klemboski, you can see that when you actually transact the palmar as well as membranous ligaments, you can see that there is some widening of the scapholunate gap. But if you actually transact the dorsal scapholunate ligament, you can see that there is a positive Terry-Thomas sign, especially when you load the wrist, and that is the dynamic instability. And when you actually remove the dorsal intercarpal ligament, you can see a massive instability of the scapholunate complex. The dorsal intercarpal ligament is actually quite a wide structure. It attaches quite widely onto the proximal carpal row, and it acts as a labrium to prevent the capitate from dislocating dorsally. Not forgetting the function of the palmar structures as well, such as the palmar scaphotriquetral ligament as well as the palmar SCT ligament. Those actually gives a significant role in the scapholunate stability. We all know about the Geisler's classification as well as the Mark-Garcia-Elias stages of instability, but we usually look at the EWAS classification for arthroscopic assessment. So usually up to EWAS stage 3C, we can attempt to do a repair or a capsulodesis of the scapholunate joint, or even stage 4. But if you have about stage 4 or stage 5 where the joint, the ligament is very unrepairable and the extrinsic ligament is very attenuated, you may consider a reconstruction. So there have been various techniques for open scapholunate repair reconstruction described in literature, but we are more moving towards the arthroscopic approach, mainly because it's less invasive. It is more precise in terms of assessing the intrinsic and the extrinsic ligament, less fibrosis, and because of the arthroscopic approach, it avoids devascularization of the carpus. Christophe Matulan has popularized this arthroscopic dorsal capsular ligamentous repair, the ADCLR, to basically reconnect the DCSS, basically reinforcing the dorsal scapholunate complex. And when the stages of the instability is more pronounced, like 3C, you may want to actually perform a wide ADCLR to grasp the DIC ligament to stabilize the dorsal scapholunate complex. This is a nice arthroscopic video basically showing the pre-ADCLR and the post-ADCLR where you can see the scapholunate joint is actually quite stable on loading. When the scapholunate interosseous ligament is avulsed, one can actually perform a suture anchor repair of the scaphoid and lunate and then perform a capsulodesis. This is a nice picture on the right side showing that there's a bare area of the scaphoid bone as well as the interosseous ligament that is avulsed off. There are multiple techniques of dorsal capsuloplasties, namely the Andre Artse technique, where basically called the round block technique. Essentially, the aim is to reinforce the dorsal scapholunate complex, as well as the supercapsuloplasty described by Gustavo. And all these basically just reinforce the dorsal scapholunate complex. Not forgetting the volar capsuloligamentus repair by Francisco Pinel, as well as Sanj Kaka, as well as the latest technique by Artse. This is one video that I just did 2 days ago, where I actually reinforced the RSC as well as long radial lunate to reinforce the volar scapholunate complex. Scapholunate reconstruction has been described arthroscopically, few techniques there, but the technique that I use is the extracapsular reconstruction. And you can see this is a static scapholunate dissociation. And I start with the 3-4 portal. You can see that there is a very thick scar between the scapholunate joint, and the scaphoid is actually subluxed and is flexed. You can see a big gap over there. And when you do a mid-carpal view over here, you can see that there is a fibrous scar between the scapholunate joint, and then usually, you want to actually debride those fibrous scar. You want to convert a static instability into a dynamic instability. And after debridement, you can see the radiocarpal joint, and you can see that the scapholunate joint after that is pretty much reducible, but because the extrinsic and interosseous ligament quality is not good, we proceeded on with the reconstruction. So this is a transverse incision, sort of extension of the 3-4 and the volar incision. And then we started off by harvesting the palmaris longus tendon graft, trimmed to 2 millimeter wide. And then we place a needle to identify the tunnel. So this is under fluoroscopic guidance. So we then place a cannulated wire. Basically, the scaphoid is dorsal distal to volar proximal direction. And you can see that when you actually clamp the two wires together, you actually reduce the scaphoid flexion into slight extension. And with that, we start with the drilling of the bone tunnels. I know some people are not into the bone tunnels, but in these cases where the attenuation of the extrinsic ligaments and so on, sometimes you may have to reconstruct as such. So this is all performed in an extra-capsular approach. I cannot see the carpal bones. It's all from fluoroscopic guidance. So this is the start. We start off with the 3 millimeter bone tunnel on a lunate bone, and then followed by a 2.5 millimeter bone tunnel onto the scaphoid bone, as shown in this diagram here. We then pass the tendon on the lunate bone from dorsal to volar direction. And then the tendon graft goes through the scaphoid from volar to dorsal direction. So essentially recreating this box reconstruction concept. And then the tendon is then moved again from dorsal to volar direction. That's why the lunate bone is 3 millimeter, allowing passage of the two times, the tendon passing through both times. And then I place in a biotenodesis screw to prevent chiseling of the internal brace, between the internal brace and the carpal bones. So this is the biotenodesis screw placement, and then placement of the internal brace suture tape from Artrex, or from dorsal to volar direction, and then tying the internal brace at the floor of the carpal tunnel. So after tying, you can see that from the scope, the scapholunate joint is more stable. And then when you do a fluoroscopy to sort of load the wrist, you can see that there is no widening of the scapholunate gap, and this is obviously just after the reconstruction. So this is the outcome at 2 years. I just called this patient up. Actually, it's quite good. He actually started to go back to function at about 3 months with a good grip strength as well. And this is at 2 years follow-up with no pain, and he's actually generally quite happy. So this is another case, basically a scapholunate static instability. You can see there's a wide SL gap over here, like shown here. Then after reconstruction, you can see that the gap is actually closed, it's stable. And this is at about 3 months. Just did this patient fairly recently. The grip strength is still quite low, but he's recovering. He's generally quite happy. The scar is actually relatively minimal. And this is at 3 months follow-up with relatively painless. But you can see that the scapholunate gap is a little bit widened right now. But generally, he is quite painless. So in summary, we do not know the right answer. There is a spectrum of soft tissue injuries in the scapholunate complex. And arthroscopic management or arthroscopic assessment is essential tool to assess which part of the complex is affected. The technique of scapholunate reconstruction and repair is evolving. There's been a role in volar, capsulodesis, and so on as well. And essentially the aim and the concept is to reinforce the extrinsic stabilizers. Whether bone tunnels is good or not, we do not know. There is no right answer to it, but of course Greg Bain has shown that bone tunnels may cause problems with chiseling and so on. So yes, so that's my conclusion for now. Thank you.
Beautiful presentation. Any comments, any questions at the floor?
Can I just want to know what is the usual size of tenodesis screws you use in lunate and how often you are able to use? These lunates are so small, so what is the size of the tenodesis screw you are able to, especially
if I'm not mistaken, it's about 3 or 4 millimeters. It's from the Artrex, a small tenodesis screw.
the smallest, because our population, we find that using in lunate, it's quite very too small to, that's one difficulty.
Yeah.
Thank you.
But if you use 4 millimeter screw, how is it like 4 millimeter drill hole that you do? Because I think that sometimes lunate can be problematic with the tunnel?
It can be problematic. So that's why when you actually drill the bone tunnels, you have to make sure that your bone tunnel is center, about 3 millimeter away from the scapholunate joint, and really slow drill. Slow drill and just keep flushing with water and saline. Generally is quite safe, but then again, my numbers are quite low, n equals few. So for now, the outcomes have been quite good. Of course, Greg Bain's paper as well talk about the problems with internal brace, with chiseling of the bone and so on, and the tendon graft, and you really cannot replace a ligament with a tendon. So we are still looking for the right answer, but the essential aim is basically to reinforce the extrinsic stabilizer. So the role of reconstruction actually is quite narrow. Very few people need reconstruction.
Thank you. Thank you very much.
Thank you.
Next, I would request Dr. Prashant to deliver his talk on dorsal capsulodesis of SL injury, arthroscopy.
Good afternoon. My sincere thanks to the organizers for giving me the opportunity, especially Dr. Bharat. So we'll go to the talk. So I will concentrate more on this, only the dorsal capsulodesis as an arthroscopic method. The most intrinsic ligament injuries of the wrist. It could be pre-dynamic to an advanced scapholunate collapse. It is why it is important. It is more predisposition for a degenerative joint diseases. Of course, we have a thorough understanding of the anatomy and biomechanics, which we are doing it in the morning. So scapholunate couple is a complex anatomic and biomechanical zone. Yes, of course, the advent of arthroscopy has turned the dogmas regarding the understanding the lesion as well as the biomechanics and what are the alternative methods that we can propose for this. We'll do a little bit of for the anatomy. It has 3 distinct areas: palmar, dorsal, proximal part, depending upon the various other histological component. It could be fibrous, it could be fiber as well. So initially we thought more so of the most dorsal component. The dorsal component of the SL ligament is the thing. But volar component as well as the interosseous ligament is also plays a very important role in maintaining the stability. Yes, classification in touch, the Gisler's classification arthroscopic 1, which will indicate the level of the injury, attenuation of the either ends of the scapholunate ligament as well as the stability in the midcarpal zone. It is under various stages, 1, 2, 3 and 4. And further advanced, as the earlier speaker mentioned regarding the EVAS classification, it not only indicates the which part of the ligament is involved, whether the palmar part or the volar part, and whether it is associated with a volar disc instability or a dorsal instability. What are the options we have? So earlier it has been arthroscopic debridement alone, or debridement with a close pinning, or you can use a radio shrinkage and a capsular ligament shrinkage, and of course the procedure which we are talking, and reconstruction a little bit it has been summarized earlier as well. And of course, in capsulodesis, if there is no much remnant left, we can go for an anchor. So this is a hallmark paper published by Christopher Matholin. He is the person who is involved in with this technique. And of course, my friend, my partner, Abhijit Vayagaonkar is also involved in this repair. So most cases of scapular seems to be classical dorsocapsular arthroscopic repair is one of the technique, one of the method. I cannot gold or something like that. It mainly based on the augmentation of extrinsic as well as intrinsic capsuloligamentus structures. That means to tell that it is based on 3 scapholunate locks. What is that? Dorsal intercarpal ligament. DCSS means the capsuloligamentous septum, scapholunate capsuloligament septum, and the interosseous scapholunate ligament. What are the prerequisites for this technique? So it is based on there must be some residual ligament on either side of the bone, that is on the scaphoid and lunate, and it should be repairable, and it is NF40, that means the duration. If it is very long duration, that may not be that much helpful. And the intact DCSS septum is also important because our whole technique based on reinforcing, and hence it is going to help us. Just have a care evaluation of this thing animated way. So all portals, viewing portals are ulnar portals. All working portals are radial side. So either it could be midcarpal or radiocarpal. So idea is go and put something on either side of the ligament which is remnant is present. Look through the radial ulnar portal and try to retrieve to the midcarpal portal. Make a knot and come back to 3-4 portal and put a knot that is going to put those dissociation to normal. So this is another case where there is a dissociation of the scapholunate ligament. This is 3 or 4 months old. So we are making a radiocarpal portal. First do a radiocarpal portal, do a very good synovectomy and debridement. And then go to the midcarpal portal, again do a good synovectomy. At the same time, assess the scapholunate instability, whether it is there or not. If it is there, what is the classification? What is, as well as assess the remnant ligament stretches, how they are repairable or not. If they are repairable, unrepairable. If the DCSS is not intact, then we may have to look for other options as well. So this is the normal anatomy where we can see a scapholunate ligament through the radiocarpal portal and the DCSS and the midcarpal portal also. You can put a small probe and assess how much is there, whether how much the ligament is moving or how much the probe is involving, whether it is type 3 or type 4. At the same time, assess the either side of the ligament stretcher. So once you debride this, through the look through the ulnar portal, do the radiocarpal, then go to the midcarpal portal, shift the portals and do a debridement. So here, entry to the radial, first thing is the entry to the radial remnant and retrieve it to the midcarpal portal. So the retrieve it to the midcarpal, which you are doing it here, and once you do the ulnar remnant, make a knot here and push it, which will approximate it. So this is the retrieval to the radial. Once you have done the radial, you retrieve it, go to the midcarpal and retrieve it, and then come back to the ulnar remnant and retrieve the same thing to the ulnar one. Once you retrieve that, then go to the dorsal aspect. See, this is how. Go to the dorsal aspect and to the extended incision, pull it through the radiocarpal portal, which is going to get approximated something like this. So here, only problem is that there is an intra-articular knot, which is going to sit inside the midcarpal joint also, plus through the radiocarpal portal, dorsal ligaments, all the 3 components are repaired, which is supposed to give some sort of stability to the ligament, and that is going to repair. You can immobilize with any wires, 1 wire, 2 wire, through the scapholunate or a scaphocapitate, immobilize for around 4 weeks, maybe 6 weeks sometimes, depending upon how much repair it is. So this technique is based on augmentation of intrinsic as well as the extrinsic ligaments, which are going to embrace the which is going to support the scapholunate ligament, and further, this seems to be essential in maintaining the scapholunate stability, and most unless it is grade 5, grade 4 or grade 5, where there is not much ligament remnants are present, then this method may not be that much useful. So it's a valuable adjunct not only in evaluation as well as in repairing the scapholunate ligament injuries. Thank you for your kind attention.
Any questions?
So, do you do it for the acute as well as chronic cases?
Yes, sir. We can do say up to maximum up to 6 months we have done. Okay. So where important is while doing an evaluation, if the remnants are good, if you can see both the remnants, then it is useful.
So in chronic cases, when the DC has happened, so do you radiologically with the image intensifier restore it?
Always, always. Especially in those cases, achieving a reduction is a very big difficulty. Hence, very nice thorough debridement is required, then only we will achieve a reduction. Even the earlier speaker I showed using some wires to reduce it. In those sort of cases, very nice debridement will help us in achieving reduction.
Because it will tend to go back.
That's right.
So you will reduce and fix with K-wire and then repair.
Correct.
Right?
Correct.
I have a quick question. So in the Matholin's technique that you were presenting, you grab the ligament remnants, but I think that the newest arthroscopic dorsal capsule desis techniques, they don't anymore do it because it's actually for many surgeons it's kind of hard to grab the remnants.
Correct.
What do you think about that?
Correct. So if that is the case, then we can. They are using nowadays. They are using a thin wire loop, which is very useful rather than to retrieve these threads, especially fibrous and all. Yes, of course, it's very difficult. The wire loops which are thin, as well as they are devoid of any knots. We are not putting any intra-articular knots in the mid-carpal joint. That will be very useful.
Hi. The first speaker, Dr. Chung, told us about a 360-degree reconstruction, and she doesn't do much to the dorsal ligaments, the extracapsular ligaments, the extrinsic ligaments. You are telling us about focus on the dorsal part of the interosseous ligament and the septum. Why does your technique work and why does her technique work? If they are mutually exclusive almost.
Yeah, see, in this technique we are not only considering the dorsal as well as the interosseous ligament is also very important. Okay, that's why, and the whole complex, if the remnant is present, it is going to give stability. If it is a very old one, then that is true. Then we have to do a 4-corner sort of thing. Can add?
Hi, actually our technique is pretty similar because the technique that I use, the 360, is actually the extracapsular. So essentially the tendon graft and the internal brace actually goes around the scapholunate 360 but outside the capsule. So it essentially incorporates the extrinsic ligament name as well at some point in the, not the DRC but rather the DIC and volar side as well. But for the dorsal capsulodesis, I did discuss also, and we had a long discussion. I had a long discussion with Prof. Greg Bain as well. Sometimes the dorsal capsulodesis may not even work if the DIC ligament is avulsed off from the bone. So you really have to assess the entire complex, not just the dorsal SL ligament, but also the intercarpal ligaments and the attachment of the DIC ligament, if you're talking about the dorsal complex. Yeah.
And added to that, usually the box concept works much better in acute and even chronic situations, whereas this dorsal capsulodesis, there's no role in chronic situations at all. Because even though Mathola says that it works, but there won't be remnants to stitch at all. Especially once you debride that, there's nothing there to repair it. So there's hardly anything, because you want to reduce it, you debride, then finally nothing is left there. So you need to do a box concept for chronic.
Yeah, if only possibility is, if only one part is not there on the bare scaphoid, there we can put an anchor and try to do the same technique sort of thing.
Okay. Next, I would request to Dr. Sunil to speak on wafer resection.
Thank you, chairpersons. Good afternoon, everyone. My talk would be on wafer resection through arthroscopic, a brief introduction into where exactly it started from. It is indicated predominantly for what we call as ulnar impaction syndrome or ulnar carpal abutment, which is totally different from your ulnar impingement. So this is a ulnar side wrist pain either in a neutral variance or a positive ulnar variance, and it is predominantly and pathologically a chronic compressive overloading. This results in a chronic conflict between your ulnar head and the proximal lunate, and there the changes of all the pattern which I will show subsequently will happen. If you see the normal loading pattern, about 80% of forces go through the radiocarpal joint and 20 through the ulnocarpal. But there are many studies which show that a slight alteration in this variance can alter your loading pattern also. A 2 mm increase in the variance increases the load to almost double, that is 40%. Similarly, even 1 mm can increase up to 25%. There are many papers which suggest that that millimeter of sequence is important. So that is what I was saying about a neutral or a positive ulnar variance. And before going to a pathological variance, some physiological changes what happen have to be noted, especially in terms of when you pronate your forearm, your radius gets relatively shortened. So that's the difference between a PA and AP view. And when you dynamically load it, like in a clenched fist view, you find the ulna moving much distally. So with these two physiological changes happening with rotations, there is something called as an idiopathic positive ulnar variance, where there is no history of injury. There it is just an abnormal loading in a inherently ulnar positive or a neutral variance, or a dynamic ulnar positive variance, happens mostly in sports person or work related. If you look at the pathological part of ulnar positive conditions, you have the most common is a malunited distal radius fracture. You have your XX lopresti with radial head excision. You have your Madelung's, your growth arrest, and the Galeazzi fractures are some examples for ulnar positive conditions. So does this happen only when the ulna is long than radius? Definitely not, because even in a neutral or a negative ulnar variance, there is an inverse relationship between the variance and the thickness of the TFCC. So negative variance may have a thick horizontal running TFCC, so ultimately it can still grind against your lunate and cause this conflict. It starts as a degenerative tear in the central portion of the TFCC, prolongs to a chondromalacia or cartilage changes in the lunate and the triquetrum, then attritional changes in the lunotriquetral ligament, and finally LT arthritis. That's the stage 4 of the Palmer classification. Symptomatically, patients present with ulnar side wrist pain, which is predominantly exacerbated by your ulnocarpal stress test, where you ulnar deviate and rotate the forearm, and during power grip the symptoms are increased. DDs to be considered: you have your ulnar styloid impaction, where the unusually long styloid can impact. You have your degenerative or traumatic TFCC lesions, which do not show changes of ulnar impaction. Your ECU tenosynovitis and your LT ligament isolated injuries can also mimic this kind of clinical picture. So what are the MRI changes when we suspect this kind? Whether it's a positive variance or a neutral variance, changes do happen. And in the T1 image, you find the hypointense patch on the ulnarmost corner of the lunate, and the gradient sequence of still image shows hyperintensity. Sometimes you see cysts, which may involve up to the mid half of the lunate as well. So evolution of the treatment of this started with the ulnar shortening osteotomy described by Milch, which is a very good procedure. Then if your distal radial ulnar joint is arthritic with rotational limitation, then you can go for a hemiresection, and wafer resection was described by Felden. There are some other radical procedures no longer indicated for this particular indication. So what exactly is this wafer resection? This started as an open procedure where the amount of variance is measured and that segment of distal ulna is resected off, preserving the ligaments. So the indication of wafer was limited only to variance difference of less than 4 mm, because this is an arbitrary thing, because with every millimeter resection going on, the contact forces in the distal radial ulnar joint sequentially increases. So the more you resect, more the contact forces increase, and it ends up with a painful rotationary movement. So then developed the concept of arthroscopic wafer resection, where you get access to the ulnar head either through a pre-existing tear in the central part or your surgically created tear, or if it's totally intact, you can even go through your distal radial ulnar portals and go ahead with your wafer resection. And you can also address the cartilage lesions and tears at the simultaneously. So advantages of this are: it allows decompression as well as debridement and repair in a single procedure, less surgical pain, less disruption of soft tissues, does not require bone healing or internal fixation or implant removal like your ulnar shortening osteotomy, shorter immobilization, quick return to work. And one indication specific for this, if you have a reverse oblique configuration of your distal radial ulnar joint where the ulnar shortening is contraindicated, US wafer is one procedure which would actually help to some extent within the limits of 4 millimeters. Contraindications for this procedure: any arthritis, any variance more than 4, a minus variance to some extent, any instability pattern on the ulnar side. So this starts with a scopy, both at the midcarpal, radiocarpal. You debride the central perforation, enlarge the perforation with a shaver, and then go ahead. So you start with the, debriding the overhanging synovium on the ulnar side. Inevitably, all of them have this typical central perforation of the disc. I use a wide bore needle as a knife to just make it fast, enlarge the central perforation, taking precautions not to injure your dorsal or volar ulnar ligaments. You can use graspers and punches as well. And as you start smoothing out with your shaver, you start seeing your ulnar head, the white shiny structure on the undersurface. And then you enlarge the tears to a sufficient size that you can access the entire ulnar head. So once you get that access, you start shaving it off with your shaver or a burr. I prefer a shaver because it tends to suck out the debris and makes it easier, but if the bone is hard, you can use a burr as well. Starts in the center, and with rotation of the forearm, you access different parts of your ulnar head. With pronation, you get more of volar ulnar head. With supination, you get more of dorsal ulnar head. That is one thing, along with moving or pushing the ulna with your thumb. Do not leave any grooves, and the amount of resection can be measured with your probe or with the diameter of your shaver blade. So that's how the rotation helps you in accessing the area of required resection. So as you start using your shaver blade in this case and removing the cartilage, you find that cancellous bone coming into picture, and the healing process is such that you get a clot over there which converts into a fibrocartilage and helps in relieving. So with further pronation, you get this volar aspect of head which continues to be resected. And the typical appearance of a arthroscopic wafer resection is a curvilinear helicoidal shape, but with open resection you don't get that pattern of resection. It's more of straight cut on the ulnar side. Always avoid injury to the sigmoid notch and verify the integrity of your distal radial ulnar joint at the end of the procedure. So if you don't have a tear, there is a procedure. I don't have any experience with this. The scope goes into your distal radial ulnar portals, and you just do the same procedure through a separate volar carpal portal. Post-op rehabilitation, short duration of splinting, movements exercises allowed from 2 weeks, and grip strengthening after 6 weeks. Complications, persistent abutment is a known complication because of either incomplete resection because of the maneuvers which have been not done, or sharp margins or bone fragments, and because of injury of ligaments you can get instability. So in summary, arthroscopic wafer is a reliable procedure in idiopathic or pathological ulnar positive or neutral variants in ulnocarpal impaction syndrome. Dissection of less than 4 mm is easily tolerated, and it's an easy procedure with reproducible results with very less complications. Thank you.
Thank you, Sunil, for that excellent presentation. Is there any questions for Sunil?
I can give a comment and ask one question. I was just in ASSH Minneapolis, and there was this session about the big names of wrist arthroscopy, Lee Osterman, Paco Pinal, PC Ho, and so on. And at least one or two actually say that they would not recommend doing arthroscopic wafer resection. I'm not sure what is the problem about it, but at least I usually struggle to getting in everywhere the same resection, especially the dorsal side. I don't know if it's that I haven't been pushing with my thumb, as you said, so maybe I can solve the problem with that, but
2 mm resection, I wouldn't do it for like significantly positive variants. It's hardly 2 or less than that, because ulnar shortening looks like too much for that, just 1 or 2 mm of recession which is needed. And like you said, there is some amount of bone always left because we can't go to the extremes on the volar or dorsal side, but that sufficiently decompresses the central part, which is the pathological part for the patient.
Do you use image intensifier to test again how much you are resected, or you don't?
Not necessary. For these subtle changes, it's not necessary.
Is it okay to make that central tear complete? You know, you have a small tear with a small flap of tissue there, and now you are making a huge hole there for the wafer procedure. Is that okay biomechanically? And I mean,
like we don't know whether the tear is the cause of pain or the impaction is the cause of pain, and this procedure is addressing both of them. So I don't think it causes any significant alteration in the mechanics of the ulnar side of the wrist.
Yeah, if there is a central tear, then definitely this is going to help.
Yes.
Again, the question comes, if there is no tear, then a DRUGoscopy is going to help. Again, to resect it through the DRUGoscopy is very challenging.
Very challenging.
if there is no central tear, I would think at least twice that was the diagnosis right, because for me, there can't be ulnar impacting syndrome if there is no central tear, but that's my thoughts.
Sunil, just sorry if you mentioned in the earlier part of the talk. So, do you do power grip views to catch the ulna in the act of hitting the lunate?
Yes.
Do you do power grip?
Yes.
So, if you have a positive ulna variance, a dynamic positive ulna variance, which is a lot, so do you sort of move away from the wafer and come to an ulna? Or in other words, what is your thing which clinches your decision to do a wafer as opposed to an ulnar shortening?
It is not to be seen in isolation. Like I would combine my stress views along with MRI findings. And like I said, if the TFCC central part looks okay, I would prefer going for ulnar shortening. Then I would skip and abandon the procedure and go for ulnar shortening if I feel there are MRI changes on the lunate. But there are many positive idiopathic ulnar positive which are asymptomatic as such. So probably this may trigger the pain, but that itself may not be the case because it has been there for the patient since long time. So anything more than 2 or 3 mm, I would go for a shortening or shortening as well.
So which means in your dynamic grip views,
yes,
if it's going 2 to 3 millimeters or anything more than that, you will come for an ulnar shortening.
I would come back for ulnar shortening.
Thank you, Sunil, for that excellent presentation. Now I invite Dr. Darshan Kumar Jain to talk on TFCC arthroscopic management. Over to Darshan.
Okay. Arthroscopic TFCC repair. So my overview of this is basically in anatomy and how to diagnose, and few points on how to intervene, and mainly much of my is on methods of arthroscopic repair. So we all know these are the components, that's the central and the dorsal ligaments and the meniscus homologue, and as well as the ECU subsheath, and as well as the volar and the dorsal ligaments. So when you see all these components, so it doesn't look, when you do an open procedure, you don't see it like this, whereas an arthroscopic gives you a benefit of viewing the entire TFCC complex. And as I propose this iceberg concept, what you see is only the tip. So the foveal insertion and the rest of the DRUJ which already been discussed. So that we need to keep in mind when dealing with these problems. And typically a patient has a fall on an axially loaded and a pronated and dorsiflexed wrist causes a TFCC injury. And some of these instruments which cause torque, that also causes pain or the injury. And pain on mainly on gripping and ulnar deviation is one of them. So I typically use standard classification. This is the PAMA classification which I tend to prefer. That's the central and the ulnar side are the distal means radial and the ulnar and the distal ones. So what are the tests what you use? Basically foveal sign is one of the most common sign which I would prefer to do. That is the tenderness of the soft spot, especially on ulnar deviation if you have. That's one thing which I would. Ballotment test I would always think in terms of I need to be, that means if it is positive I would always think that the injury is much more severe, and ulnocarpal stress test. So these are the various tests. However, as I told, the foveal test is one which I would want to this thing means given more preference. And surface anatomy, because my fear while operating a TFCC is am I missing out on something else which causes ulnar side wisp pain, that's why. So surface marking is very important, or you identify these and follow this as a 3-floory structure. That's a means you take as a DRUJ and below as the lower floor and the middle floor as a radiocarpal and the midcarpal joint as the upper floor. And the investigations are the mainly typically X-ray and MRI. CT arthrogram not much worse, but if at all you want to see some bony lesions, you could do that. And a true PA view and comparison with the opposite side, you need to assess the, also need check about the variance as well. And arthrography, I have no idea about this. MRI is what, and preferably a 3 Tesla MRI, which is what I prefer. And the foveal insertion is what always my focus will be, and always try to look for something in the midcarpal joint as well. So this has got a sensitivity of 1.5 Tesla, almost 84%, and a 3 Tesla MRI of almost 95%. So there is a lot of, and arthroscopy is considered as a gold standard to identify. So these are the differential diagnoses one has to keep in mind while looking for a TFCC injury, because these, as I told, I'm worried more about these rather than the TFCC alone, but that am I missing on any of these? And while arthroscopy, these are the things which you want to know. You want to know the trampoline test or the ballotment of the articular disc, how the consistency is. That's one thing which you want. And also the hook test. You want to know whether the foveal insertion is intact. And recently it's also mentioned, this paper says the hook test is not pathognomic. That means you need to do a foveal scopy as well. That means you need a smaller scopy as well. If you use only 2.4, you may not be able to access this and you will get a false positive. So this is another test which is a ghost test where you open the shaver and do a suction. The TFCC rises up. That tells you either it's a big dorsal capsular tear or mainly a foveal tear. That's what it's mainly indicative. That's a shaver tip which you open it and assess the raising of those TFCC. That's elevated. That's what tells you the TFCC stone. And what are the guidelines? Mainly the type of injury, location of injury, duration and ulnar variance is what guides our management. Much of the time, if they're present initially, you always strive for a conservative immobilization with a cast, definitely gives good results. And if they have instability and foveal tenderness, that's where you need to repair. Depends, the surgical treatment always depends on the site of the tear, and central tear, many of times we debride, unless you have some exceptions where you have that flap which is repairable, you could use it. And type 1BC conservative management, and type 1D prefer to do an open treatment. So this is a very complex classification. Just that's why I use ADZE is this thing. That's why I use a PAMA classification, which is simple, and always you can use variants or if at all any bony component is there. So timing, less than 3 months is relatively good healing, and 3 to 6 months unpredictable. More than 6 months definitely a poor healing, because there are chances that some arthritic changes would be there if at all there are some fractures. Some technical highlights on the dorsal capsular tear. So you use two sutures. One is the lasso, the other one is a PDS or a fiber stick which you could use. Retrieve it outside and put a knot on the outside. So this knot can be troublesome. You need to know to cleanly bury this. And also this is another case where a dorsal capsular tear, sublux TFCC, 3 months post injury, still complaining of pain, persistent pain. So once you see, you can see the dorsal capsule is easily, it's quite floppy and you can easily lift it off. So that means there could also be we did this thing, foveal scopy as well, means that's, we visualized that was intact, but the dorsal capsular tear was quite big. So once you debride that, I used PDS for this case, which was reason. So that's the first suture. Sorry. That's the first stitch. There's a second suture, second PDS, either use 3-0. That's a third PDS. So once you grab all this, you're visualizing with 3-4 portal and working through 6U or 6R portal based on your tear location. Once you repair them, generally that's how you could complete release the traction and tighten them. You check before you release them. So this is what the Jeff Eckers paper, which mentioned about the visualization of the foveal attachment, because you need to do. This is a normal one, the first A, and the second one is you have some abnormal tissues along the C also. There's absent foveal insertion here, and this is an unhealthy tissue. So this needs to be debrided. So this is how you do. You visualize through the mid-carpal the radiocarpal portal. Then finally you insert this thing through the 1.9 scope. You could use that. Can I get a minute? Yeah. So this is the foveal insertion. You can see this is the raw area where it's supposed to be. So that's where you could mention that thing that there's a foveal insertion is bad. It's not there. And you could use TFCC jig to, this is a lady who had got a distal radius fracture, not unable to supinate, mild variance, and post 3 months after the injury as well, not able to, there's no supination there. So a lot of arthrofibrosis was there. So you debride that. Once you debride, you could do even a free hand, or a jig is quite convenient if at all, but you need to know the projector, because sometimes these KYs tend to converge. So this is a fiber wire which you use 4-0. Can I get a minute? So use a push lock or the knotless, because these knots should not be palpable outside. So because that is actually annoying, because a lot of them complain of that problem because of the knots. So this is what is a jig, which were either at a single tunnel or a double tunnel you can make it. These are another, some variants like central tear. Sometimes they may be amenable to repair. So this chap had come to us with a lot of pain, but still persistent. So we managed conservatively for almost 2.5 months. So then we see this, did his MRI. So you see some soft tissue interposition here at the dorsal border or the rim of the DRUJ. And essentially still painful. Supination was restricted for this chap. So on arthroscope we found that there was a large central tear like this. So generally we see central tear and we tend to debride. But here we saw that MRI had some soft tissue interposition. So this was something like a bucket handle tear what you have, and this fell well within the margins of the repair. So we repaired this as well. So if at all you're not able to repair, then only debridement will be the only option. So you use fiber wire and as well as a dorsal capsular repair as well, you do that. So always remember to rule out the other differential diagnosis of these TFCC injuries. Don't try to treat the MRI. Many of this MRI has reported falsely as TFCC tear, and use a technique which is comfortable to you. Thank you very much.
Thank you, Darshan, for that excellent demonstration. We'll allow 2 questions to Darshan.
This is Dr. Vishal from Bhopal. I have a patient who has a foveal avulsion, symptomatic, and 1.5-year-old trauma. So need to repair it or reconstruct it?
What would you do?
No, 1.5-year-old repair generally will not be. Before that, you need to do assess if at all he has got any DRUJ arthritis. Rule out all the extra-articular causes. That's very important because your variance you check, mid-carpal joint or any of these LT injuries could be associated. And always when see TFCC, just don't jump at that. LT injuries also cause similar type of pain, but only on loading as well. So you have to rule out. And 1.5 year just TFCC repair may not give you a good result. So be careful on that. Thank you.
Yeah. So what is the post-op protocol for these patients here?
Usually, initially, I always used to put them on 4 to 6 weeks of above elbow slab. But if it is a fresh tear, I just manage with a below elbow slab itself for initial 3 to 4 weeks. Above elbow is less tolerated. That's the reason actually. Many of them start by 2 weeks itself tight or removed. So it's a fresh immediate that's like within a 1 month. So I just immobilize with a below elbow slab and then go on to mobilized. After that, I protective splinting for another couple of months.
Yeah. Thank you, Darshan.
Thank you.
Now I invite Dr. Mikko Raisanen to give his delivery talk on STT joint fusion arthroscopy. Over to Dr. Mikko.
Yes, as already heard, I'm going to talk about the arthroscopic STT fusion. So I have been in Arthrex wrist and hand arthroscopy course in Munich 22, and other disclaimer is that I love wrist arthroscopy. This is our paper. We presented our case series of 5 wrist and 4 patients a few years ago. STT osteoarthritis is quite common cause of radial side wrist pain, but most of the patients can be treated conservatively, and at least I try the conservative treatment as long as possible. I'm not so eager to operate these patients. Faded conservative treatment options are trapeziectomy, STT partial resection arthroplasty, open or arthroscopic, STT fusion, open or arthroscopic. In theory, arthroscopic procedure has advantages over open procedure, preserving biology, maybe faster union, less traumatic, faster recovery, and better mobility. But I had to say that I'm not always so sure if they are true in partial fusions, and especially if somebody does arthroscopic total fusions. The intervention begins with standard arthroscopy, the radiocarpal and unocarpal joint arthroscopy. Everyone knows how it's done. And then we go to mid-carpal joint, and the first portal is mid-carpal ulnar portal. And then you plan and do the mid-carpal radial portal viewing from mid-carpal ulnar portal. I would do it more distally and radially, the MCR, than normally. Confirm STT osteoarthritis, which is usually easiest from the MCR portal. Plan and do the STT-U portal. If you have performed very distal and radial MCR, it can work as STT-U. If not, plan and do STT-U when scope is in MCR. At least one accessory portal is usually needed, and it can be STT-R or STT-Palmar, which one you see the best. Sometimes you can do also both. I don't think you can do too many portals. Debridement with shaver or microwaper. Article surfaces are denuded using 2 to 4 millimeter arthroscopic burrs. I try to get always as big as possible. It's much faster. Usually these operations takes time, too much time in my opinion. Perform dry or wet scope, which one you prefer. You usually have to use at least some saline. Syringe is good. You can put a syringe in the arthroscope and use vacuum of the burr or shaver to irrigate. Cancerous bone graft can be taken from iliac crest or distal radius. Distal radius actually is enough. I think that maybe we need less than was priorly thought. Pack the graft to bone biopsy cannula or cannula of the burr or shaver. Not too tight, because then you have a hard time to get the graft to the joint. Insert the graft to the STT joint and pack well with instrument, for example, dissector. Release traction, cannulated scaphotrapezial and scaphotrapezoid screws are usually good, and you place them under fluoroscopy. K-wires are also a good option if you don't like screws or you can't get them. And it should look something like this, but maybe this should have been a little bit deeper and maybe a little bit shorter, but it's okay. Post-operative protocol, immobilizations 2 to 6 weeks, removable orthosis after 2 weeks, active non-weight bearing exercises after 2 to 6 weeks, weight bearing about 6 to 12 weeks. So let's look at our case series. We had, as I said, 4 patients with 5 wrists. All of them were blue-collar workers. And follow-up was 5 months to 4 years, average 18 months. Here is one example, isolated STT osteoarthritis. Here is another example, maybe actually the same patient, I can't remember. And if we look at the portals, we used plenty. As I said, I don't think there can be too much. You have to see and be able to do the operation well. We used mostly the iliac crest, but I would say that now I would use maybe the distal radius because it's near. If we look at results, fusion was achieved 4 out of 5 wrists. 1 we didn't get, which I'm not really happy. If we look at the RS angle, I don't think it's so good as it should be. For example, the first patient, it was more post-operative. Grip strength, again, not so well, reasonable, but not really good. Range of motion, again, I would have wanted better. For example, if you have 50 degrees, 40 degrees, or even 30, as you can see in 4th patients, not well. That was okay. Again, 4th and 5th patient, they had about 5 even. That's quite a lot. Complications, not so many. We had only 1 non-union, as I said. And then the 1st and 2nd patient, they had problems. The first one had symptoms, and then he had signs of AVN in lunate. Is it related to operation? I'm not sure. And the 2nd patient, we had the trapeziectomy and scaphoid distal bowel resection. Then if we compare the results to open procedures, which I'm not really sure if we should do with few patients, grip strength was 70% of the contralateral hand in arthroscopic, and open was 76%, so better in open. But again, I don't know if it's really right to do the comparison. Extension 86% and flexion 93%, open a little bit less, 70 to 80%. Again, we looked at true discussion. Bony fusion, only 80% of the cases. Again, we had 5 wrists, so it's really hard to say what is the real answer. But the findings are pretty similar than example Ho and Bauer had in their articles. 1 patient developed avascularity of the lunate, similar findings than Kinberg. No other similar cases in literature, so I can't say for sure if it's related to treatment or not. Slightly better flexion extensor range of motion and slightly worse grip strength. But remember again, 5 wrists, hard to say anything. Arthroscopy STT fusion takes time. For us, it took 2 hours at least, many cases, even 3 hours. And probably hard to be more cost effective than open option. STT fusion at all may not be the right answer for isolated STT osteoarthritis. I'm not sure. Watson had good results, but then the other ones have struggled to show the same results after him. Partial STT arthroscopic resection might be answer. I think it's easier, and I think the literature shows pretty good results with that. And that can be performed similar technique as described in this presentation and article. I hope you like the presentation, and I hope many of you will come next year to FESH Helsinki 25. It's the first time in Finland, and I think we will have a great conference. Thank you.
Any questions? Thank you, Mikko. Request. You have a question? Sorry. Mikko, you have a question. Sorry.
Thank you, Mikko. Sometimes we get patients with quite severe STT arthritis where there's so much scaphoid erosion, the scaphoid is now vertical, they have a DC collapse of the lunate. Can you correct that angulation arthroscopically, or would you then prefer to go open?
You should be able, but as a wish, in our results, we had a little bit struggle with the RS angle, but it should be possible. But of course, you can't correct the DC. Will the DC be problematic later? I don't think we know, but it is not easy operation, and correcting the scaphoid in exact right angle probably really hard.
Thank you.
Okay. Thank you. Thank you, Mikko. Request Dr. Amit to speak upon scaphoid non-union arthroscopic management.
Very good afternoon. I thank organizing committee for giving me this opportunity. So why scaphoid non-union is a problem? Because it is devoid of periosteum. It is an intra-articular fracture and synovial fluid continuously ingresses at the fracture site. Fracture is mobile because both the pole lies along both the carpal rows, and in long-standing cases there occurs dizzy deformity. And we all know about the vascularity, which is very precarious, and it goes from distal to proximal. And the most important factor for scaphoid non-union is displacement at the fracture site. So our aims for the treatment of scaphoid non-union are achieving union of scaphoid, which can be done by using cancellous bone graft and stable fixation, and restoration of the length and restoration of the alignment of the wrist by correcting carpal instability. So scaphoid is an almost entire intra-articular bone. So it is logical and reasonable to work on the scaphoid arthroscopically, because as we put the scope, we directly reaches to the non-union site. And the most important advantage of this procedure is that we hardly see any scar on dorsal and volar aspect of the wrist, and rest of the people don't know whether surgery has been done or not. And another very important advantage of this procedure is that it preserves the tenuous vascularity around the scaphoid, because we are not cutting any important ligaments around the scaphoid. And along with that, whenever we are doing wrist arthroscopy, we can identify concomitant radioscaphoid arthritis, TFCC injury, scapholunate and lunotriquetral ligament tears. So whenever we approach the wrist for this procedure, we use two portals, midcarpal ulnar and midcarpal radial portal. Midcarpal ulnar is mostly a viewing portal, and midcarpal radial will be the working portal. So this midcarpal ulnar portal is basically a portal between four important bones on ulnar side of the wrist joint, and midcarpal radial is just distal to 3-4 portal. So once we put our scope inside, so we are here in the scaphocapitate joint. On right hand side there is non-union of the scaphoid, and on left hand side there is capitate. So in lot of cases there is fibrosis at the non-union site. So our first job is to open up the non-union site. It can be done by a sturdy probe, and after that use either shaver and burr. So here the most important thing is to remove the sclerosed margin at the non-union site. Nicely remove the margins of the distal pole, proximal pole, and slowly go inside and create a cavity at the non-union site. And just try to leave some cuff of tissue, a cuff of cartilage on one side, so that bone graft should not go out in the radiocarpal joint. And the most important thing, step in this procedure, arthroscopic bone grafting. Cancellous bone graft, we use for this procedure cancellous bone graft harvested from the iliac crest region. We made it into small pieces, and with the help of a sleeve we pass it into the non-union site. And the graft volume should be 3 to 5 times of the defect. Nicely impact the cancellous bone graft in the distal part, in the distal pole, in the proximal pole, and it provides a nice scaffold at the non-union site. And after this arthroscopic bone grafting, next is fixation. Whatever method we are using for fixation, it should prevent bending, pronation and shearing forces during fracture healing, and it should give stable fixation. We can use screws, we can use K-wires, always 2, not 1 K-wire. We will see some cases. This 26-year-old gentleman, he presented with non-union since 4 months of the waist region. So we did arthroscopic bone grafting for him, and fixation was done by using headless compression screw. 4 months post surgery, scaphoid was nicely united. And see, this is the beauty of this surgery, right and left hand of the patient. We cannot make out whether a surgery has been done or not. And he has got reasonably good range of movement at the wrist joint. Another patient, this 30-year-old gentleman, he presented with proximal pole non-union since 3.5 months. So we did again arthroscopic bone grafting. Here the important thing is, a lot of times whenever we do bone grafting, the graft just goes into the radioscaphoid joint. So for this, to prevent this, we use urine catheter number 6, inflate the balloon and then do bone grafting. And after removing the catheter, do again arthroscopy of the radiocarpal joint and see whether there are any remnants of the cancellous bone graft or not. If there are any, we can remove it. Then fixation was done by using 2 K wires because proximal pole size was very small in this case, and the scaphoid got united after 4.5 months post surgery. And this patient has also got good range of movement at the wrist joint. Another case of distal third non-union of the scaphoid. This was a 5-month-old non-union. So here the important point is, it is very difficult to approach this distal non-union through the midcarpal radial portal. So we need to do an additional portal, that is STT portal. So here we are seeing through the STT portal, we are bang in the distal third non-union of the scaphoid. On left hand side there is non-union, and then do nice compacted cancellous bone grafting at the non-union site, and again fixation was done by K wire since the size of the distal pole was very small, and this also got united nicely at the 4.5 month post surgery, and he has got good range of movement at the wrist joint. So there are some contraindications to this procedure. In long standing scaphoid non-union with significant carpal collapse, we cannot do it. In severe snack race changes, likely to preclude good outcome, so better to avoid it. And if we see literature, there is a very nice series by Professor PCO, 125 arthroscopic bone graftings, and he has included cases of delayed union, proximal pole non-union, revision surgery. In spite of that, overall union rate was 90.3%. Another series by Professor Liu Bo, and he has 20 cases of proximal scaphoid non-union only, and all fractures united within 16 weeks, and it was confirmed by CT scan. So this arthroscopic bone grafting for scaphoid non-union is a very good procedure. Thank you very much.
Any questions?
For bone grafting, do you use dry scoping?
Yeah, at this stage, we just stop the water flow. I do wet scopy, but at the time of bone grafting, I just stop the water flow and wait for, I do suction 2-3 times, let everything dry, and then do bone grafting. And lot of times I use glue also at the time of bone grafting.
How many portals do you use, Amit? How many portals do you do? Because we see you're seeing through the scope, you're impacting bone and also using another impactor at the same time. Means you're
2 portal, mid-carpal radial, mid-carpal ulnar.
But you insert the bone graft also and the impactor also in another adjacent one more. This thing. Okay. Same through the same portal you're using.
Yeah, same portal. Yeah.
Okay. Thank you.
Yes.
Yeah, I just have to comment that, as I said, I love wrist arthroscopy, but I think that not everything is always better arthroscopic than open. For example, maybe the partial fusions. But I think that seriously, scaphoid non-unions, it's superior to do it arthroscopically than open. And I think that there is actually pretty good literature behind it. And I think that actually maybe even the proximal probe fractures, arthroscopy is even better in that than the waist fractures.
Yes. Thank you.
We conclude this session. Thank you. Thanks all the speakers. Thank you very much.
Thank you, delegates. We appreciate your time and efforts in making today's session a success. Your engagement and enthusiasm were contagious. Thank you for your valuable input and participation. Thank you. As we embrace in this conference journey, let's reiterate a commitment to a responsible healthcare practices and compassion and continuous learning. Let's now begin a session on topic piercing together the puzzle, managing scaphoid non-union. Now, I humbly request the chairperson, Dr. Srinivasan Rajapan and Dr. Amitav Gupta on the dais, please.
Good afternoon. This is a session on scaphoid fractures and non-unions. This is supposed to be a case discussion, so we'll do a case-based study. So what I'll do is, I'll first present a case, then I'll have different people come up and give different answers to the questions posed. So this is a 19-year-old boy who fell playing soccer. He fell on his outstretched hand, and then he was seen in the emergency room. And these are the x-rays that were taken in the emergency room. Now what do you see? Any fractures of the scaphoid? I guess you need more x-rays, right? So they got an oblique. Any fractures? Perhaps not. So the patient was put in a splint and asked to come to the office. He did not attend for another 2 weeks, so he ends up in the office in 3 weeks. So 3 weeks, this is his, when he comes to the office in 3 weeks, this is his view. So we'll leave it here. Let's stop this and go to the next. The question is, when you have a wrist injury, what are the diagnostic algorithms that you want to address? So to answer that, Vineet, the boss, will come and talk to us about diagnostic algorithms.
Thank you for this opportunity. And disclaimer is that after preparing this talk, I'm not wiser. I'm more confused. So can I have the first slide, please? So when to suspect fracture, as the case has been presented, a patient with outstretched hand and radial-sided wrist pain. We look for tenderness at the various spots that are described, and we go ahead with x-rays. Standard wrist PA view, the scaphoid being flexed in relation to the radius. So we get an ulnar deviation view where the scaphoid stands out and can show a fracture site in obvious fracture. A lateral view is mostly because we want to see the carpal alignment. The pronation oblique view helps in looking at the more distal fractures, the scaphoid tuberosity fractures. And then to complete the series, we get a supination oblique view. Not sure if this is the best one for scaphoid fracture, but it is to complete the series here. The problem is that after clinical examination and x-rays, many a times we are not wiser and we still have a doubt whether there is a fracture or not. The specificity of these signs are quite low. And 30 to 40% fractures are still missed. It can be overdiagnosed or underdiagnosed, both are possible. So we, as Dr. Amitava has just said, we put in a plaster and send for 2 weeks. But in today's time, is it actually wise to immobilize all suspected fractures or leave it and risk a non-union? So can we make an early diagnosis? So recent trends are towards getting more investigations. CT scan is useful. It can show the fracture when it is not visible on the X-ray, and it can show other features which I'm sure will be covered in the non-union aspect. The things to consider here is that the cuts should be less than 1 millimeter. Now we can get 0.6 or 0.5 mm cuts also in the newer CT machines. And the axis of the scaphoid the cuts have to be in the axis of the scaphoid as shown in the video here. In this particular patient, the scaphoid is still standing upright. The more scaphoid is flexed, the more important this aspect goes. Now this is something which we have to see. You know, this is the disadvantage of getting a CT. That to an untrained eye, the vascular channels can look like a fracture. The thing is that we look at consecutive cuts, not just one cut. We move from one side to the other, and if the line persists through the cuts, then we are more suspicious of the fracture. MRI has more or less become the favorite tool. It can detect fractures early, and the features we know. But the thing is that are these really fractures or just bone bruising? That is a conflict which I'm going to try and bring out with the literature review. Bone scintigraphy is mostly disadvantageous and not popular now. Is MRI the best modality? We look at the systemic review, 15 studies, 1102 patients. Very specific, 99%, both CT and MR. This is the Cochrane review, where 11 studies were considered. Again, very specific, very sensitive. The CT scan sensitivity is lower than the MR in this study. However, this paper came out in 23, and it talks about overdiagnosing scaphoid fractures. Are we actually looking at actual fractures, or we are looking at bone bruising and treating them? Out of a good number of cases, only 2% had definite fracture, 4% probable fracture, and there were 29% patients, according to the authors, who were non-specific. The thing is that the criteria of saying that it is a true fracture was very rigid. They wanted to see a transverse line on the MR to say that it is a true fracture, which I think would be visible on the CT also if we actually see these patients. The second point that the author has said is that even if there is a occult fracture, does it need treatment? Will it heal on its own? If it is missed, we can treat it and give good results in future. But then this study in 24 shows 6.3% non-union rate in patients with occult scaphoid fractures, which are picked on MR, but not on CT scan also. So, these are just recent, and I guess even with the Cochrane review, we don't have an answer which one is better. The problem is that we don't have a standard to compare these investigations against. When do we say there is a fracture or there is no fracture? Do we wait for 6 weeks? Most of these papers have considered X-rays at 6 weeks as the standard of declaring whether there is a fracture or no fracture. So we don't have a set standard, and the incidence is low, so the tests become unreliable. In summary, clinical suspicion, get X-rays, make sure we have all the proper X-rays, CT scan in the axis of the scaphoid, thin slices, and make sure that we are not looking at the vascular markings instead of the fracture. MRI has a good negative predictive value. For me personally, I would get an MRI, and if it is negative, my life is easier. At least those 60–70% patients who would get a plaster are not getting a plaster now. The problem is with the occult fractures, and that I think is still need to be answered as far as the literature is concerned. Thank you.
That was excellent. So basically what we should do is find out. So we know what are the diagnostic criteria. The Duckworth from Edinburgh, he came up with his own criteria, the clinical criteria, Duckworth criteria. So now we've seen this patient who has, at 3 weeks, a DZ deformity. You think that maybe a scapholunate gap. So are we going to do an MR, or are we going to do a CT scan? That's the key question here. So next, can I have the next? So the question is, which ones are good actors and which ones are bad actors? And how do we pick those out? What is the literature just tell us about different types of scaphoid fractures? Yeah, take it. So we've come to this patient. So we did a CT scan because there was a DZ deformity, and look, 3 weeks. And you'll see this in adolescent scaphoid fractures quite frequently. Patient has got a DZ deformity, it's flexing down, It's a humpback deformity, and interscaphoid angle is quite high. There's a DC deformity. Now, what are the poor prognostic indicators? Displaced, literature shows this very clearly. Displaced fractures, unstable fractures, that means fractures which have different patterns, the vertical oblique fractures, and fractures with carpal instability and deformity, part of a perilunate injury pattern, and proximal pole fractures. Take it home. These are the 4 types of fractures with poor prognostic indicators: displaced fractures, unstable fractures, fractures with carpal instability and deformity, and proximal pole fractures. So, in my mind, the indications for primary ORIF are these: displaced fracture, unstable fractures, transscaphoid perilunate dislocation, proximal fractures. So you want to, if you can pick up these are the bad actors. You pick these out and you fix them, and the rest, we'll talk about it in a little bit. So displaced fractures are treated operatively, and this was a study by from Joe Dias's unit, and they looked at 7 studies for non-operative treatment. They had 93% healed with cast, 15% displaced. The non-union rate was 18% in displaced fractures. Displaced fractures are 4 times higher risk of non-union. This kind of displaced fracture, this kind of displaced fracture are part of a perilunate injury pattern. So proximal pole fractures are notorious. So these are the bad actors. So once we know the bad actors, we can fix them early and get on with our life. So proximal pole fractures are really bad things. So 34% progressed to non-union in Eastley's study here. So what do you do about the rest? We'll talk about it. Now the next question is, how do we treat them? So acute scaphoid fractures, current treatment algorithms. Ajish will talk to us and educate us how we treat those.
Well, thank you, sir. Good afternoon, everyone. Yes, so my talk is mostly in, as he intended, is not on cases, but on what does the best evidence, where does evidence take us regarding the treatment of acute scaphoid fractures. So now the situation is that we know there is a fracture. There's no issue with diagnosing a fracture. We already know that there is a fracture. The question is, what next should I do? And well, the choice is straight away when you're seeing these patients for the first time, for all scaphoid fractures, what you're going to think of is, am I going to cast it or are we going to fix it? And so I'll start off with the non-operative management part of it. And so it is the preferred treatment for stable, undisplaced waist or distal pole fractures. And we have multiple studies on these. They are referenced below. And we can achieve near about 90% union in these fractures treated conservatively. And obviously, if they have low complication rates, they do not come with the complications associated with surgery. But then the question of types of immobilization as well. What sort of cast are we going to apply? I think it's been clear for many decades now that an above elbow cast is definitely not required. But then there is no indication for a thumb immobilization as well, and a standard below elbow cast reception. This was a prospective trial from the US, and they were quite clear. In fact, they found a better rate of union with a cast which did not have a thumb extension. So the cast to use would be the standard short arm cast, which does not immobilize the thumb. And now the length of immobilization, this could be quite interesting. Now, how long should we immobilize them? And this wonderful study from Nottingham actually showed where they immobilized these patients for just 4 weeks in a cast, took a CT and found that 85% of those had actually united, converted all of the patients to a splint, and at 8 weeks found that 96% of these patients had united. So, and there are other studies also which show that shorter immobilization period should actually be enough. Like this one from Ruby Graval's unit also shows when they are managing these undisplaced fractures, more than half of these are actually united on a CT scan by 6 weeks. So now the question is, okay, so the length of immobilization, when do we actually operate? And some of these are actually already been mentioned by Dr. Amit. But then the 2 reasons that we need to operate. One is to have better chances of union, The other is probably to achieve faster union. And so we'll take up the latter first. Regarding faster union, there has been, let's say, conflicting opinions and high quality evidence that is actually conflicting. But this meta-analysis by Al-Naeem actually showed that for minimally displaced fractures, or undisplaced fractures, surgical fixation actually has a significantly lesser time to union, which is about 30 days less, and they also return to work about 38 days faster. But of course, they had a relative risk of the complication rate of 1.47 times the cast group. But then, I think the most well-quoted study in all of probably scaphoid fracture disease would be the SWIFT trial, where they were from Dr. Ryerson group across Europe. And so they had 439 patients which were randomized into two groups. They were minimally to displaced fractures comparing a protocol which initially treated them non-surgically. And the whole point was that the outcome measure that was used was patient-reported wrist score at 52 weeks. And they found that these two groups were actually similar. And the other important aspect was there was an 8% non-union in the cast group, but 14% complications in the surgery group. So that sort of leaves it in the middle on what we should be doing. But I think one important aspect of the result was that we would need 73 acute fracture fixations to avoid one scaphoid non-union from the data from their study. So anyway, we have a study from Manipal as well, where the same sort of protocol was followed, what's called aggressive conservative approach from our secretary, Dr. Bhatt's unit. And the idea was that they started with 39 fractures, minimally displaced, and found that 21 of them had actually united by 6 weeks. And for the others, they took a CT, then underwent, the non-unions and underwent, delayed unions and underwent a fixation, and they actually managed to get 100% union. So that sort of an approach has also been put forward. So now when we come to the reason of should we do it for a better chance of achieving a union? And so the risk factors for non-union, we already seen these, Dr. Gupta has already mentioned them, displaced fractures, proximal pole fractures, or comminuted ones. But then what is an unstable scaphoid fracture? One that has a translational displacement of greater than 2 mm, has a lateral interscaphoid angle of 35 degrees, which is the angle between the on the coronal plane between the distal and the proximal pole of 35 degrees. Obviously, having comminuted fractures or when the fracture is part of a perilunate spectrum of injury. So the contention should be that we should offer fixation to all unstable and displaced fractures, because these actually have an odds ratio of about 17 to end up in non-union with conservative treatment. And in other studies, we have seen that for every half mm of increase in displacement, the risk of non-union actually sort of doubles. So by the time you get more than 1 mm of displacement, we have more than 27% of risk of non-union. So in the proximal pole fractures, under of the risk factors, greater than 50% of these fractures would end up, if they are displaced, would end up in non-union if you do not operate on them. And so this review from the evidence-based medicine handbook of 2017 showed that there's about 5 times greater risk of ending in a non-union if you treat proximal pole fractures in a cast. And again, the time for their healing is also larger. So just a couple of slides. So this was, we don't really have guidelines on these, but this one's come from Europe, and they sort of take over what has already been said on how the fracture should be managed. We can have calcium mobilization for non-displaced fractures and offer surgery for displaced ones. Proximal pole fractures, almost all of them would require operative treatment. And so the approach component is between pochetinus and open, and we could volar or dorsal. For reasons of time, I would just move forward. The volar approach has better results in short term, but not really a difference at 1 year. And the open reduction also, you can get a more central screw from a dorsal approach, apart from the vascularity issue, but then you get a longer screw from the volar approach. So again, it's going to be a surgeon's preference because there's no real evidence on any difference in outcomes. So I'll sum it up. There should be a non-operative treatment only for stable undisplaced structures. A standard short-arm cast would be sufficient. Short-term mobilization times can be considered if you can get repeat CT scans. Surgery for undisplaced fractures may not be routinely indicated, maybe a subset of patients. All displaced waist and all proximal pole fractures should be offered fixation. The approach to fixation is basically a matter of convenience and surgeon's preference. Thank you.
Thank you, Ajish. Question is to carry on with our story. What did we do next for our patient? Let's go back to, we skip all that because we've already gone through all this. Let's go to the last bit. Okay, so we are here. We've looked at the CT scans. Now there's a humpback deformity in the acute situation and a dizzy deformity. So we go from the volar side, open it up. For me, I find this much more reliable. I can open up the scaphoid, correct the dizzy deformity, and this patient wanted to go into the military, so didn't want any hardware, so we ended up fixing with K-wires, which we took out, and because it was filled with compact cancellous grafting, this healed up very readily. So young patient, dizzy deformity, diagnosed with CT scan and fixed and went on to full union with excellent function. So take home message, primary indication of internal fixation scaphoid fractures are displaced fractures, unstable fractures, fractures with carpal instability and deformity, and proximal pole fractures. Rest can be managed by cast for 4 to 6 weeks, then assessed at 6 weeks with CT scan as according to the SWIFT trial of Joe Dice. Thank you very much. Next we'll go on to scaphoid non-union, and Srinivasan will take over that section.
Thank you so much, Dr. Gupta, and let's get on with this straight away. And if you do not follow what the 4 speakers have said, then you will end up with the problems we are going to discuss, which is the scaphoid non-union part. And may I invite Dr. Ehab Basim, see here, okay, to talk on the evaluating evidence-based approaches to scaphoid non-union. Yours.
Thank you very much. I'm just going to discuss the evidence, if there is any available for the evaluation of the scaphoid non-union. So everybody come across these type of non-union, scaphoid non-union, treated somewhere else and was sent to you after failure. I think the scaphoid is not different from any other bone. We need a biology and we need a mechanical stability to achieve the union of the scaphoid. And the biology, sometimes we don't have that much control of it because the site of the fracture, if there is a cavity associated, if any sclerosis, we don't have any say in that. But I think the mechanical stability, this is something we can achieve, and especially correcting the deformity. And this classic paper by Nakamura is since 1993. And to be honest with you, the point from there still very much valid. So the poor prognosis you will get if it is more than 5 years injury, it's in the proximal third of the scaphoid, there is a sclerosis. And if we didn't correct the deformity, the scaphoid or even the carpal biomechanics. And then we added the smoking, which is now, in my opinion, is a big issue regarding scaphoid union. Now, the mechanical stability, I think we moved from the fact that we need compression, because K-wire, they heal really nicely, the scaphoid non-union. So, and the K-wire, we know that they don't give any compression. So we don't need a big screw to achieve union. And the smaller the screw we're going to use, you will have a much better bone contact. And this is maybe why we're getting a really good result with the plate, because there is no metal crossing the fracture. Now, if we look at the location of the graft, everybody has a preference, and the literature actually supports you. Continue doing whatever you do because there is no much of a difference even with the meta-analysis. Is there any difference if the type of graft, is it graft we're going to use which is vascularized, non-vascularized, and the type of fixation? Not really, because if you look at even the K-wire with the non-vascularized bone graft, and there is 11 study with almost 300 scaphoid, and they have a good union rate. So that's no much of a difference, except this is a sort of a systemic review, and the only difference they found is whenever there is an avascular necrosis, then the vascularized bone graft, they will do better. Now, the avascular necrosis is a slightly controversial issue because we actually cannot say which one it has an avascular necrosis or not. Even with the gadolinium MRI scan, we are not But in this study, they say, if you think that there is a vascular necrosis, then go with the non-vascularized bone graft. This is another issue whenever we fix these, when we will allow them to mobilize, when we will allow them to go back to their activity. And this is a cadaveric study, and they looked at if the fracture united from the radial part, then you need a 25% of the union, and you will achieve 100 Newton load. So the scaphoid does not refracture. But if it is from the ulnar part, you need a 60%. So this is something that you need to take in mind whenever you review your CT scan post-operatively. Now the plate is becoming, I think, more and more popular. The Maastricht midterm result from Netherlands, they are actually excellent. It's a 96% union rate, but they identified the fact that we need third of them, they need to be removed, these plates, because of the impingement in 1 year. But when we look at the meta-analysis from all the studies regarding the headless compression and the volar plate, not much of a difference. The only thing we tend to use the plate in cases which they are complicated, revision with multiple fragment, so that we cannot use the K-wire or the screw. So looking at the literature, how am I going to treat this one? I think I will go with the vascularized bone graft, because I think there might be some avascular necrosis, so I want to give the best chance for this patient. And I will still go with the screw, but I will go from the dorsal. And the one thing I will say that the most important part is preparing the bone itself. You need to take your time to debride it, pack it really nicely. And the packing issue is I almost have the X-ray or the image intensifier in the operation that the scaphoid bone will look the same density. This is how much I packed bone. Then you can fix it, and they do heal really nicely. So the take-home message, I don't think is changed in the last 20 years, maybe best just for the mechanical stability. Now we have more evidence, but still it's a poor prognosis if it's performed, the surgery, you did it after 5 years, sclerotic proximal pole, unsatisfactory reduction of the scaphoid or the carpal deformity. No evidence that a single graft better than the other. Ask your patient to stop smoking, and there is no superiority for a screw over a K-wire or a plate. Thank you very much.
Thank you very much. And to just to summarize what I learned from those 5 minutes, the first thing is that you don't need to put a very big screw. If you have a choice, choose a smaller screw, which is something I learned there. And then I'm just making it very simple, irrespective of what implant you use or what is your bone graft type, it's going to unite. If you do a proper job, okay, that is to be underlined. And what is a proper job is a very subjective thing. But I think we all know it when we see it, although you cannot define it. The next thing I learned is that you do, when you're wanting to decide when you want to mobilize a patient, if the healing is happening from the radial side, then it's got to heal 25% and the patient is good to be mobilized. If the healing is happening from the ulnar side, then you'll have to wait for 60%. Is that through CT scan or through CT scan? So for you to make sure that healing happens, you'll have to go back to CT scans. Right. So we go on to the next speaker, who's Dr. Krishna Priya Das, and he's going to talk to us on effective treatments for scaphoid non-unions, what you need to know.
Good afternoon. My topic is effective treatment of scaphoid non-union. How do you need to know? We know the blood supply of the scaphoid is two predominant vascular pedicle, but dorsal supply is more important. But avascular necrosis is reported 13 to 50% of cases. The rate of non-union is also high. Even in occult fracture, there is a 12% chances of develop non-union. What are the factors we consider for preventing the scaphoid non-union, or for considering the management of scaphoid non-union? It is the duration of injury, site and types of injury, body mass index, vascular pattern, initial treatment, associated injury, and also the smoking. It's just 7-month-old fracture escapade, right escapade. There is a non-union of the escapade, so we plan for vascularized pedicle vascular bone graft. Because there is a sign of avascular necrosis in the MRI, harvest the bone graft, but maintain the pedicle nicely. And debride the site also adequately. Then I fix the bones temporarily with the K-wire so that there is no kinking of the pedicle. Then finally I fixed with the screw, Harvard screw. Gives the adequate tension at the fracture site. And immobilized the below elbow cast. And in another, it is the follow-up at 5 months. Very good range of movement. Is a consolidated union as well as achieve the grip strength also. Another patient of 26 years old, police constable, come with the escapade non-union with the vascularity. But here there is also a little bit gap at the fracture site. In the MRI, there is a great area of avascularity. So I plan for iliac crest bone graft because I thought need more bones. That mass of bones is not sufficient for the distal radial pedicle graft. But adequately debride the fracture site and take the very good piece of bones and then make it the chocolate shape. Then again adequately debride the fracture site and then the bone is packed nicely, then fixed with the screw and start the mobilization as early as possible. This is the follow-up at 4 months. Very good consolidation as well as the range of movement and also achieve the grip strength. But not always need to fix the screw. It is the humpback deformity with gap non-union, treated adequately with the debridement and then takes the bone graft from the iliac crest. And here there is the only shell of proximal pole. So I fixed with the 2 K-wire. And unfortunately that day my CM was not working. So I pin is little bit more. But fortunately at 4 months there is a very consolidated non-union and very good range of movement as well as the grip strength is also good, 40 kg. What is the results between the iliac crest bone graft and pedicle vascular bone graft? Most of the the union rate, in case of iliac crest bone grafts, I get a little bit more, so 87%. Union rate is also faster, 12 weeks. In pedicle vascular graft, it is 14 weeks. Complication is also almost similar. Mass score as well as the range of motion and grip strength is also similar. Low energy falls from a standing height are the most common cause of escapade fracture. The average age of presentation was 27 years. Return to work is same in both groups. Adequate debridement, sufficient bone graft and stable fixation ensure better outcome. Grip strength compared to uninjured wrist, static, no difference between these two groups. What is the key point? Adequate debridement at the fractures and non-union side. Put sufficient amount of bone for deformity correction and maintain the length of the bone. Stable fixation, but not always need to fix with the screw. Preserve the remaining vascularity. What is the limitation of I have no experience of arthroscopic fixation, no experience of free vascularized femoral condylar graft. So conclusion is adequate debridement is the keystone for the treatment of escapade non-union. Iliac crest bone graft is a better option for early consolidated union. Pedicle vascular bone graft is also good option and less downside morbidity. Thanks for patient hearing.
Thank you very much, Dr. Das. And we'll have all the questions at the end. So we'll move on to the more difficult and the more dicey part of scaphoid non-unions, which is vascularized bone grafting and avascular necrosis and so on and so forth. Our next speaker is Dr. Anand Chandak. He will be talking on pedicle revascularization of scaphoid non-unions. Sometimes I feel Anand's and Dr. Sudhir Warrior's job is like trying to act out a part in a movie which you actually are not doing, or it's like Rajnikant doing a villain role, but still you're getting paid for it, so you do it to the best of your abilities. Yours.
Thank you, chairpersons. First of all, I would like to thank the organizers of the IFCON for giving me this opportunity. And everybody in the hall, I think, would agree that non-vascularized bone grafts for the scaphoid non-unions are a time-tested technique, and they have consistently achieved significant union rates, close to 95 to 100%, and over a period of different era and different studies, they have shown this. But this is particularly when the proximal pole was vascular. Now, when the proximal pole is avascular, the union rates with the non-vascularized bone grafts across various studies have been shown to be as low as 25 to 0%. And so, that is because of the vascularity of the scaphoid, which is in the retrograde fashion. So, if we are having a fracture at the level of waist or proximal to the waist, the chances of avascularity for the proximal pole keeps on increasing. And whenever there is avascularity, we think that we should need a revascularization. But then the criteria to determine the avascularity are still quite ambiguous and vague. And so I have tried to summarize a few. On the X-ray and the CT scans, increased radiodensity of the proximal pole after the phase of hyperemia, that is roughly 4 to 6 months. Once that is over and there is an increased radiodensity of the proximal pole, that is considered to be one of the criteria for avascularity. Similarly, on the MRI, the absence of the or the decreased signal intensity, particularly both on the T1 and the T2 weighted MRI, have to be considered as this. The consistent gold standard by the clinicians is the intraoperative assessment, the complete absence of punctate bleeding after the deflation of the tourniquet, and on histopathology, the demonstration of medullary as well as the trabecular necrosis. So, the revascularization surgeries for the non-union scaphoids are basically two: pedicle vascularized bone grafts and the free tissue transfers. I would be talking about the pedicle grafts. Again, the pedicle grafts are either the volar sided ones or the dorsal sided ones. The volar sided ones, the common one is the palmar carpal artery based graft, and this graft is harvested from the volar ulnar corner of the distal radius. The advantage of this is that it has a good robust pedicle and can be easily flipped over to fill up the side from the vascular side. The second commonly used one is the pronatoquadratus muscle pedicle bone graft. The distal part of the pronatoquadratus along with the consistent vascular pedicle is shifted to the scaphoid non-union side. So both of these volar grafts can be used for the volar sided approaches or for the non-unions with the humpbacks to correct the deformities also. Coming to the dorsal, the 1,2 ICSRA, the Zedenberg is the most preferred one, and based on the 1,2 ICSRA vessel between the first and the second extensor compartment. The second is the fourth extensor capsular artery, extensor compartment artery based graft, which is a capsular pedicle is used. And another one that is described is based on the second dorsal metacarpal artery from the base of the second metacarpal. So what are basically the advantages of the vascularized bone graft over the non-vascularized bone grafts? They bring in viable osteocytes along with them, so there is increased perfusion over a period of time. The influx of both the osteogenic and the angiogenic factors results in basically a direct bone healing, which is there with the vascularized bone grafts, unlike the creeping substitution which is there in the non-vascularized bone grafts. And thereby it is said to heal faster, more reliably, more consistently achieving better union rates. But there are also disadvantages. This is it has a high learning curve, and there is a difficulty in the surgical technique. You have to preserve the vascular pedicle nearly very nicely. Undue tension on the pedicle or pedicle kinking or the graft shattering, because these are from the distal radius, so very friable cortical support, and graft splitting or friability can lead to failure of the revascularization graft. There is a lot of literature that is coming up which is in support of the vascularized bone graft, particularly in cases of avascular necrosis of the proximal pole. And over a period of a significant period, consistent high healing rates of nearly 90 to 100% have been achieved. Along with the proximal pole avascular necrosis, the vascularized bone grafts have also had support in the cases of recalcitrant non-unions or in cases where there have been failed previous surgeries. And these are the current guidelines from Hand Clinic of 2024. Scaphoid non-unions, local vascularized bone flaps, particularly useful for proximal pole avascular necrosis. When to use? Dorsal vascularized bone grafts can be more beneficial for the proximal pole non-unions because these would not be associated with the humpback deformity and they would be having the common approach of the dorsal side. And the volar vascularized bone grafts are more particularly useful for humpback deformity correction or carpal instability cases because anyways you are going volar on those. Thank you.
May I invite Dr. Sudhir Warrior to speak on free tissue transfer for scaphoid non-union.
When you tried everything, all the above, and you still have a non-union, is there one last throw of the dice that you have still in your hand? So here's a patient who at 1 year, a young adult, and I did a vascularized 1-2 ICSRA, should have had a 70-80% union rate with a screw fixation that is supposed to increase the stability and therefore the chances of union. At 5 months, he began looking not so good as he was earlier. At 19 months, it was sure that this is not working. We changed the biology, we changed the stability, we tried to give him compression, and yet we failed to get a union. So that seems to be the story with some of these which have very little blood supply, especially the proximal pole, and especially the ones that have failed to unite despite the best care. So different papers, we've seen a large number of papers and numbers being thrown at you, and it makes it so confusing to try and decide what is happening. But here's something that is specific, looking at non-unions associated with a proximal pole AVN, and that's something that's a completely separate entity as far as we are concerned. And 10 of these patients, so equal numbers on both sides, were treated with the ICSRA and 12 with the medial femoral condyle graft. The union rates with the ICSRA were only 40%, whereas there was 100% success with the medial femoral condyle. So when you're dealing with the most difficult ones, probably there is some role for this. And it seems that they seem to unite a little faster. So we did take recourse to this procedure. This is based on the descending genicular artery. We do this with the plastic surgery team, and I think Lena is in the hall somewhere, or she's going to be speaking about this in her paper as well. And we harvest a good graft with a nice pedicle and hitch it to either the radial artery or the branch or a branch of the radial artery, and then fix it. Depending upon the host bone that is available, you choose to either you fix with wires or with screws. This is the patient who went on to union without too much pain, but of course a great restriction of the amount of movements that he regained in his hand. If there is a larger chunk, you could fix it with a screw as well, but not always would you be able to get a screw in there because of the quality of the bone that remains. So there have been a large number of publications, and I was just looking at the more recent ones, and most of them tend to give you results upward of 80% in these very difficult situations. We published these two quite some time ago in 2017. We worked on many more such cases with almost the same result. So what fails and why does it fail? And I like this paper from Wrightington, where they say you have to add the amount of time to the size of the bone, and then you get a fair idea of the ones that are going to heal or not heal. So you find the ratio of the proximal pole compared to the distal one, and you can see that as you come down, the rate of union keeps on reducing. So they plotted this against a graph, and you can see right at the top is the 1 year presentation at 1 year, and then the lowest graph is the one that is showing you the presentation at 5 years. So the 5-year non-union ones tend to heal much slower. So if you look at it, proximal to distal, so the ratio is on this, on the x-axis. And when you see that, if you got a fracture somewhere in the waist at 1 year, there's an 80% chance which drops down to less than 60 if he came at 5 years. So that's so important to understand the interrelation between the size and when you add time. So here's a patient who underwent a cancellous, corticocancellous graft fixation, corticocancellous grafting with a K-wire fixation, which didn't do too well. And he came to us at 1 year post-op, looking like that with a lot of fragmentation, and we didn't think we would be able to hold that proximal pole, and so we decided to replace the entire proximal pole using we got a model made of the proximal pole styled on the opposite side, and then created a small model which we carried into the theater and mimicked the proximal pole of the scaphoid, used the medial femoral condyle, got the graft in, and 4 months later did a CT scan to see the union, and you can understand that the thickness of the cartilage of the femur is much more than that is there in the scaphoid, and that is what you're seeing. He's doing extremely well. So you can do this as a fallback procedure when all else fails. So therefore, when I see a proximal pole with AVN or one that has failed with any of the above methods that we've seen, if there is collapse, if there is avascularity, I think that the medial femoral condyle microvascular graft will probably have a place in the treatment of non-unions of scaphoid. Thank you.
I think in the interest of time crunch and allowing more space for discussion, I'll probably give up my part of it because most of it is what's been told already. Just to add one part of it, I asked myself at the, shall we go to the last slide, please? Yeah, so that's the sum and substance of all what's been said. So I asked myself, so what do you want to tell the audience today? And I told myself, you'll have to tell the audience what you tell your patients, which means there are 329 ways of cooking the potato, and it seems like we are getting there to the number of ways of fixing the scaphoid and bone grafting the scaphoid. The union rates, if you do the operation well, are anywhere between 80 and 90%. Which means 1 out of every 10 of the scaphoid non-unions you treat will not heal. That's number one. The implant source, what you're going to use, screws, wires, whatever, if you do the job well, they don't make any difference. That's number two. I know there's a KLS Martin store outside, and I hope he's not listening to this. Now, this is the most important thing. We all have these pictures of scaphoid union where the patient is doing a good namaste and a reverse namaste. The question is, are all your patients getting this? I don't think so. At least that's not what the literature is telling. You're going to get excellent results in about 60% of patients, good to okay in about 20% of patients, and another 20, you're not going to get very good results, although your fracture would have united. The problem with scaphoid fracture literature is that most of the papers talk about union and radiological union and so on and so forth. But the patient is not worried about radiological union. The patient is worried about how well will my wrist move. So I think a reasonable answer would be to say you will get about 80% of movement of your wrist. At best, it might be anywhere between 60 and 80. The next thing is, will my wrist function very well? It's likely to function very well. Of course, if as I mentioned, about 60 to 80%, what will be the range of motion? The range of motion, again, is not full all the time. And so is the grip strength. If you look at all papers of scaphoid non-union surgery, the grip strength is not beating the opposite side of it. At best, it's about 80 to 90%. It could be related to the fact that as a part of rehabilitation, we are not doing grip strength training, but that's what it is. You're going to tell your patient your grip is not going to be the same as the opposite side, provided your patient is going to ask you for that. And function is likely to be reasonably good. So that's what I would tell my patients, and I hope the audience would agree with me on all of this. Right, so without much ado, I would open this whole discussion on acute scaphoid fracture treatment for debate and discussion. You can ask questions, you can stir the pot a little bit, and I think, do we have about 5-10 minutes time? Anybody from the organizing? Okay, let's just shoot. Can I have all the speakers in the front, please, so that the questions can be directed to them? I'll get you the mic.
We all know that there is an increased risk of failure of union with smoking. Does any of the panel not operate on patients who smoke until they stop smoking? Thank you.
Just to stir the pot a little bit, Dr. Chaitanya Mudgal in the morning said that smoking no longer makes a difference to his treatment.
There is a very good level 1 evidence that smoking actually will make a difference to the scaphoid union. And whenever I deal with these cases, I just deal with them that this is your last chance. So we want to give the best chance. And I think the spine surgeon, if anybody does spine here, they will stop their patient before they do their PLIF procedure because of the risk of non-union.
To all my Indian colleagues, because do you ask your patient how many packs of cigarette do they smoke?
The standard line is, if you are smoking, you have to give up. On all discharge.
You send the patient away?
No. I have to tell them they have to stop smoking.
No, you will tell them. That's fine.
Yeah.
I mean, all of us tell them. But the question was, if you find, there are two bits of the puzzle here, okay? There's a smoker, there's a scaphoid non-union who's sitting in front of you, you're sitting in your hospital. So he's saying he's a smoker, scaphoid non-union. Are you going to say?
Non-union, I'll give him time. Try to stop smoking, then we'll operate.
How much time do you give him to stop smoking?
At least 6 weeks.
6 weeks. Do you do this?
I just have to add an anecdotal incident. There's this young lady who's something in the film line, and she does some shooting and stuff like that. She had a non-union. She'd go down to smoke. Every time she came to see me and she was in the waiting room, she'd go down to smoke and then come back. So obviously she smelled like a cigarette when she walked into the room, and I told her, you're not going to have the chance of smoking. Please stop smoking. She united, she didn't stop smoking. So I have no idea whether my advice carries any weight with a serious smoker.
And the other issue is, are they telling the truth? They may come and tell us that they have stopped smoking. How do we trust them? So then, ultimately you have to take it with a pinch of salt, I guess.
Yeah, so which means then the quoted union rates have been impacted by the smoker, which we haven't actually pulled out these out of that equation. So we don't know the union rates.
Of course, the other thing is that it depends on what sort of a system you're working in. If you're working in the NHS, you can ask the patient to go and come back. If your patient is a very high profile, like some of your patients, you have a film star in front of you who's got a scaphoid fracture and saying, I can't give up smoking, and you're not going to send him off. Right? So it's a little bit of a problem, I agree. Samrat?
It's difficult to understand about the fracture healing when the patient comes out of the cast with stiffness and everything. So what is the best time to take the first X-ray after doing a scaphoid non-union fixation?
What do you do?
Or what is the policy? I mean,
Okay, I will, usually they will have a volar sort of a slab or a back slab for the first 2 weeks. So after I change that to a full cast, this is where I do my first X-ray, which is in 2 weeks. And this is your baseline X-ray, so that you can assess it. And then I'll do 6 weeks, and then 6 weeks, this is where you do your CT scan. So after 3 months from the operation, you do your CT scan. And this will give you an idea about, are you doing okay or not?
one more technical issue. When we have got a bad scaphoid non-union and we are doing a lot of dissection and debridement, we are not able to completely repair the ligament which we are supposed to repair. So what are the consequences we should expect? Or at times we take a bite that is through the volar capsule to the ligament, and then we are tying it all together.
You're talking about the radioscaphocapitate ligament,
Yes,
which you
yes,
sometimes
yes.
have to cut to access.
Yes, you have to cut.
I mean, any of the...
So any trick to do it better?
I generally do the, I open the lesion by the nerve sparing approach that gives you two nice flaps, and then you can easily suture that back.
Thank you.
About the indications for surgery, thank you for presenting about the SWIFT trial, which I think is maybe one of the best trials ever in hand surgery. The Clemenson protocol for surgery, I think it was before SWIFT trial. So whoever can answer, what are your indications for surgery in scaphoid fracture, and what means displacement fracture for you?
Anybody, any of the panelists can take that question. Rajesh, you want?
Yeah. So I would actually, in case possible, it's not always possible, but I would say in case possible, I'd always like to get a CT scan first up. This is assuming that this is not knuckle fracture and that we have a clear-cut fracture line seen on the X-ray. If it's not obviously displaced, I would like to get a CT scan. Anything above 1 millimeter as reported by the radiologist in a well-done CT scan, which is along the axis of the scaphoid, I would take it as displacement. I talk to the patient and tell them that you have high chances of ending up in non-union, so you should get operated. Anyone who is not displaced on an X-ray, the fracture line is still visible, I would still offer them, because there is a chance, if they are a high demand individual, there is a chance that they will want to get back to work faster, want less time for splintage. So I would still offer them in case they are ready to choose that option. So the SWIFT trial, yes, it works in a system which is similar to the NHS, but I'm not exactly sure if it works the same way in India. So I don't know what other Indian surgeons feel.
Yeah, because I think the SWIFT trial was kind of sad for people like me who likes to operate, because I think it was like 3 to 4 millimeters, even the step or gap, and still they got the same result with conservative treatment. And they couldn't prove anything that was faster healing or anybody was happier with the operative treatment. So, but I just think that it's so good trial and so good evidence that even I keep myself really good surgeon, I don't know if I can actually win the result, but I hope I can.
But I suppose the truth sucks. So the thing is, I mean, I always felt that, see, the Indian hand is very different from the Western hand. The SWIFT trial was done in a Western community. Now, in the Indian hand, for 90% of the things you do on a daily basis, you're going to touch water. We eat with our hands, we have to wash our hands. We don't eat with a fork and spoon. And in the restroom, we use water, no tissue paper. So patients find it extremely difficult to wear a cast for that long a time. So in that sense, I think, should we tweak our demands slightly differently and offer this patient an operation not supported by the SWIFT trial? I completely get it, but the SWIFT trial did not factor this part into it. that you just get a splint, you start moving your wrist, you go to work.
Yeah,
because most of our Indian patients are like Cristiano Ronaldo. If they don't go to work, there's no pay. The government is not supporting them. So there's a little thing you can't get into a trial.
You are
right?
stirring it up a little. Yeah, but I must say that we can adopt something like that once we have a good audit that we are not doing more harm by operating. Because I think right now, the learning curve for the average orthopedic surgeon treating a scaphoid fracture in India, I think we'll do more harm if we move right now. Once a certain level of expertise has reached, maybe this is something that we can resort to.
But if you say that the Indian population is different than English, and I would really like to see a trial that shows different than SWIFT. You have a great big country and you have a lot of patients. So why don't you make a RCT in India and then show that actually the result is different?
The trial can be done right now, like the Lalonde trial. We can offer everybody a below elbow cast and then wear it for as long as they can. And let's see how much of them line up for the cast removal in about a couple of hours. Everybody is going to line up there. You can't wear it. It's just extremely difficult. I mean, if anybody disagrees with me, please. We'll take one last question because the organizers want us to.
Just to comment, this is the philosophy of what to do when you have treatment uncertainty, which is you know the diagnosis and you have a range of options. And one solution for that in public health is to get evidence-based medicine, and that's what the SWIFT study does. But I think to a specialist, that doesn't tell you what to do, but it probably tells you the default. And it said, when you talk to the patient, you say, all else being equal, here's the evidence, which is probably treating you in a plaster is the default option, and it's what most people do around the world. But for particular reasons, I think because of your background and your job, and my background and my job, and my experience, I think we can argue out of that one. The alternative, if we ignore evidence-based medicine, is to have our personal bias, which is normally a school of thought. It depends where we trained and who our mentors were, which of course is not scientific, but it might be quite wise. So I think we're talking about that difficulty in treatment uncertainty and what rules we apply and whether we use the evidence out there, which is imposed on us, or our own internal wisdom. Does that make sense?
The evidence or the eminence-based medicine. Again, there's a cultural difference here because you experience that here, that you ask the patient, this is what we can do for you and what do you want? And the patient is saying, you're the doctor, you're supposed to tell me. I came here precisely, I can't choose, you have to tell me. So again, there's a little cultural difference. Again, I don't know whether you experience that in your practice. I experience that quite a bit.
But if
I'm asking the patient, look, the chances of you uniting are pretty much the same, but you won't wear a cast. And then he's saying, look, you do what is best for me.
But if you tell the patient you don't know,
Sorry?
if you tell the patient you don't know for sure the best answer, they don't necessarily lose confidence in you.
That's again a cultural difference. I mean, how many of you here tell the patient you don't know something? That's fantastic, okay. But most often, I also tell my patients sometimes I don't know something, but they sort of, you're supposed to be knowing, right? Okay, right, I think we are running out of time, and thank you very much for this, for participation, and thank you very much to the organizers for giving us the opportunity to do so. Thank you.
Thank you, sir. Thank you for your valuable contribution. Your